So we're going to cover the same illness, cardiovascular disease, and we're going to go through a couple of cases here to try and obviously this is being given to the Harvard medical students where we do case-based learning. And so we'll walk through some of these cases and see exactly how our own individual biases and individual racism has led to deleterious outcomes inside our cardiovascular disease and health. And so case one, a patient presents to the emergency department with chest pain. He's diaphoretic and visibly uncomfortable. He was walking up the stairs when the pain started and it radiates to his left arm. So exertional chest pain, visible signs and objective signs of discomfort. This is a clear-cut story for ACS. And the question is, how can the race of this patient have any effect on his care? And we're going to talk about racial disparities specific to emergency medicine, mostly because I'm an emergency medicine doctor and I like to point fingers at ourselves as opposed to others. But if I go to any specialty and I've done this, you can easily replicate some of these data points inside every single individual specialty, right? And so it's not unique to emergency medicine, but we'll pick at our own specialty for a little bit here. And so with the chest pain evaluation in the emergency department, there's so many different parts to this, right? And I'm going to go through each and every part and see and show literature that supports the fact that African Americans are treated differently than our white counterparts here in the States. So beginning with triage. Triage is a big part of our emergency medicine system here, right? The sickest get seen first. We prioritize those who have time and need. And unfortunately, we've done a plethora of studies here that have demonstrated that the emergency severity index score, which when it is lower, patients will be seen first. So 1 would be the highest. African Americans tend, on pretty much every study that I've seen measure this, have done worse or had higher scores on their average emergency severity index score. And in this specific study done in 2013, they separated it into chief complaints. And what they found is this chest pain and shortness of breath, right? And chest pain being the second highest killer of any chief complaint, but the highest litigious, or the most likely to get sued for any complaint. So it's a killer, right? It's a big priority for us is to manage chest pain in the emergency department. We've actually showed a 20-point difference in the average emergency severity index score and a 20-point difference in the average shortness of breath severity index score between our African American and our white counterparts. And to put it in perspective, for abdominal pain, there's only a 4-point difference, right? And so that's a huge gap inside the scale that they're using. We've been able to replicate this study in a number of settings. We've done it in the pediatric department, and this was done in 2016. It's big data, over 50,000 patients, right? And what they showed was lower scores for subjective complaints, such as breathing difficulty or abdominal pain, but also objective complaints, such as fever. And they divided the patients who would eventually require hospital admission. And for a pediatric patient in the emergency department, that's our sickest of the sick, right? Most pediatric patients do not require hospitalization. So even your sickest kids who have shown up and demonstrated that they're ill have lower triage scores than their white counterparts if they're African American or Hispanic. And we went to the Veteran Affairs Association and did the exact same thing in 2016. And this is another one where they use a subjective measurement, such as pain score. If you look closely, African Americans are that red dotted line and black or white patients are the black straight line. And we found that even the African Americans who report a 10 out of 10 do not come to the same emergency severity index score on average as the white patients who report no pain at all. Right. And so it never actually closes the gap, no matter how much the intensity of pain is. And then if we go over here and there's an objective measurement with the heart rate here, it isn't until about 180 beats per minute do we actually mitigate or eliminate that disparity here. Right. And so at that point, patients are rolling in complete extremis. Right. They should be seen immediately if their heart rate's in the 180s. And unfortunately, we've seen this data replicated time and time again. They've controlled for socioeconomic status. They've controlled for geography. It's a common issue here. And so now once you've been triaged, what is the likelihood that you get the accurate or correct diagnostic test ordered for you for an evaluation of chest pain? And this was a study that was done over 10 years and it had like 78 million visits. And they found that some of the basic requirements of an evaluation of chest pain, an EKG, cardiac enzymes, cardiac monitor, and pulse oximetry, African Americans and Hispanics were less likely to have those ordered than their white counterparts, right? And they've controlled for a number of confounding factors in this study as well. And we can move forward. Once you get the test ordered, what is the time to the diagnostic test? And specifically, the EKG, which is a critical time-limited diagnostic study, right? And the reason is that 90-minute door to PCI time that we hold as a national metric here in the United States. And what they found is they divided it between those who had a myocardial infarction at the end of the day and those who didn't. You had double the time to EKG if you had a myocardial infarction. And that 11 minutes is about 12% of your door to PCI time that you're losing just by being Black, right? And that has to do with the triage scores and a number of other factors, but still, right? And so you're already losing 12% of your door to PCI time, the classic phrase, time is heart tissue, right? And this is exactly what we've demonstrated in this study. And now once you finally get the EKG, what is the likelihood that you're going to have your diagnosis of your myocardial infarction missed? This is a study that was published in the New England Journal of Medicine in 2000, and it was actually just looking at all risk factors for missed myocardial infarction. And they found that non-white race is 4 times more likely to have the diagnosis of a myocardial infarction missed, but also 2 times more likely to be sent home from the emergency department. And those mortality rates for those missed myocardial infarctions and to be discharged inappropriately is through the roof, right? And they thought it was so much so a risk factor that they included it here in the bottom of the left-hand corner of the screen. It's the same category as a normal EKG with an odds ratio of 4.5. They considered this as just as much of a risk factor or in the same category of risk factors as a normal EKG. And they looked at a number of things, being female, chief complaints, not necessarily being chest pain. And this is the data that they found. And so essentially in every category, and we can talk about even more subcategories such as risk stratification, we've seen these disparities play time and time again. And they've not just one study, but a plethora of studies that have demonstrated removing any of the confounding factors and also just highlighting that potentially there is some biases in the way we're treating our patients. Case 2. And so once again, this is part of the lecture is going to go through a number of cases. I want you guys to understand the variety, the complexity, and the magnitude of these disparities that we've seen here in the United States and this is about 2 to 3 decades worth of racial disparities, health disparities literature, and emphasis on such. And so case 2, patient's a 23-year-old otherwise healthy male who presents to the emergency department with a diagnosis of appendicitis. He's otherwise healthy and presents with his fiance. The vitals are normal except the patient's febrile, right? And we'll ask the same question: how can the race of this patient have any effect on his care? And the answer, and we'll talk about racial disparities and pain management here. This is one of the original godfathers of the racial disparities movement, and it's because it's such a subjective and fascinating thing, right? And so in 1997 through 1999, they did the first study that I was able to find over this, and it was published in 2003. And what they're finding is that African Americans are receiving less pain management than their white counterparts, and they controlled by illness type. So all patients, if you look at the black bar, not to be confused, is the white patients, and it's higher in every category, whether it's for just all patients in general, migraines or back pain or fractures. And this is studying who received an opioid prescription. So there's a disparity even in fractures, right? And this is before the opiate pandemic, right? And so we're not able to use that as a confounding factor. But really what it shines light on is how insidious and difficult it is to pinpoint these disparities, right? Because I don't think, and I have a fundamental belief that no doctor in the United States woke up one day and said, if I have an African-American patient, I am going to treat them this way or a different way or worse, right? And I refuse to believe that people went in through 10 years of work and studying in their own curriculum and sacrifices so that they cannot have a desire to treat each patient they see to the best of their ability, right? And so this was just such an impactful study, and they've replicated the study time and time again, right? And so much so in 2019, they did a systematic review. And what they found was African Americans are 38% less likely than their white counterparts to receive analgesia for acute pain, and that includes non-opiates. So any pain, right? If you come into the emergency department, you're less likely to even get Tylenol, than your white counterparts, right? And this is studying the pediatric population, the metropolitan versus non-metropolitan population. It's been studied in socioeconomic differences, right? And so they've tried to eliminate every potential confounding factor. And at some point, we have to start to believe the data, that this is definitely the case, and this is something we're all susceptible to, right? And case 3, our final case, a young Hispanic mother brings her 3-year-old child to the emergency department for the evaluation of head trauma. And the question is, what role does race play in the reporting of abusive trauma in our pediatric patients? And a better way to describe this question is, 1, are minority children more vulnerable to abusive trauma? And 2, are we over or underreporting minority children's abusive trauma? And so we're going to talk about racial disparities in the management of suspected child abuse next, right? And this is one of my favorites, right? Because this is a benevolent act, right? You are advocating for your patients when you're reporting child abuse. Takes time, it takes effort, it takes energy. But we also know that child abuse mortality rates are through the roof, right? And so if you have a missed episode of child abuse, that could be your last chance at intervening. So much so that in the United States, they looked at any child who has died from domestic violence. And within the last year, about 30% of them had a healthcare visit with a documented finding that could be typical of child abuse, such as old bruises, a change in their comfort level in the exam, or something alarming with the parent. And so 30%, right? And so a lot of these cases have the ability to intervene upon, right? And so advocating for the patient is something that you're doing as benevolent, right? And so let's look into this, right? And so there's a study here in the Journal of Epidemiology that actually showed at similar popularity levels, right? And so we do admittedly have difficulty. If you're a low income, you have a higher likelihood of engaging in or being a victim of child abuse, right? As a high income earner. Well, at similar poverty levels, if you can control for that, right? White rates of childhood maltreatment trend higher than African Americans and Hispanics, right? And secondly, there's something called a Hispanic paradox, where they found that Hispanics, even at low income levels, trended much lower rates of child maltreatment than their white and African American counterparts here in the United States. And they blamed it on a couple of things, right? Like religion, cultural values, family values, immigration status, a couple of things that they could justify it for. But the fact is that at similar poverty levels, white children are just as susceptible to child abuse as their African American and Hispanic counterparts, if not more. Well, we actually find ourselves reporting minority patients 2 to 4 times as much as our white counterparts for suspected abusive head trauma than our white counterparts, right? And 4 times as Hispanics and 2 times as our African American patients for this study. And this was done in 2018, so we can't say this is a product of the 90s or the 80s here. This is modern literature, right? And what does that do? What does this actually say? That we're inappropriately in magnitudes accusing certain patients of child abuse. And this is, just to clarify, the study actually eliminated the obvious egregious cases, right? They focused on this very narrow window of a minor head skull fracture, right? And so the gray area in which this could be on the fence, and they found this data to be relevant, right? And what does this do? First, it lands on the front page of the New York Times, right? And so, and the sad part about this isn't that our colleagues, our peers in the international community are being exposed to this, but more importantly, our patients are reading this, right? Our African American and Latino patients are reading that if they bring their child into the emergency department, that they could be accused of child abuse if there's a physical accident that led to some head trauma, right? And what else, right? And so how does this impact the family? The family is more likely to receive invasive testing like full body x-rays, family defense attorneys, and this is already a vulnerable population. So paying for a family defense attorney is more difficult typically for this population, given the differences in socioeconomic status. And also any brief stint in the foster care program or separation from a family member has been demonstrated time and time again to have horrifying and deleterious effects on the psychosocial health of the children, right? And lastly, this is what I alluded to earlier, that trust in the healthcare delivery process, right? This is already at risk groups. They are reading the newspapers, right? And the big fear is that their child needs healthcare and they don't bring them in on time, right? And so, and this is an example of how difficult this conversation is, right? And these are people, doctors that is, who spent 10 years of their life training for this moment and are terrified of the repercussions of missing a child abuse case, and yet they are causing harm by these disparities in their accusation manner, right? They are causing harm by doing this. And this is why this is one of my favorite cases here. And so the question is, after all, and I could go for hours, I have dived into the disparity literature to an extent that is both painful, but also just incredibly enlightening, and where all these disparities are creeping in and finding themselves. And we have to ask ourselves why. And the answer is, and this is what I fundamentally believe in, what most of these papers have argued, is that there's subconscious bias. And the reason we have 2 to 3 decades worth of literature and replicas of each and every study that have controlled for confounding factors such as socioeconomic status, location, geography, provider, all the different things, is because what they're trying to do is highlight that this is secondary to subconscious bias. We are trying to pinpoint that out. The next question is what is subconscious bias? And if this is causing all these problems and health disparities, how do we correct for it? How do we find it? And the closest thing we have to a true measurement of subconscious bias is this thing called an implicit association test. And subconscious bias is synonymous with implicit bias. They're colloquial terms that have been interchangeable. 1998, Harvard, the University of Washington, and the University of Virginia all tried to do a joint initiative and made the implicit association test. And if you guys haven't been exposed to this, I strongly encourage you, Google implicit association test. It takes about 5 minutes to do. It's free. And what it does is, and you can look at, it highlights potential biases that you have based on the way you answer test questions in the test. And there's race is the most popular one, but there's gender biases, there's body habitus biases. There's a number of ones that you can look at. And this is one of the most well-cited psychological developments in modern literature, and probably one of the most famous in colloquial and just general layman society. And so the better question, though, is if we can identify subconscious bias with this test, we have to ask ourselves, is there a clinical correlation to the test, right? Is this test somehow highlighting those who would be susceptible to biases within their practice? And should we do something about it? And the first time that this was attempted, this implicit association clinical correlation, was in 2007. And this is a fascinating study, not just because what it found, but just because the creativeness of the literature. And what they did is they gave over 200, almost 300 residents in both internal medicine and emergency medicine. And you guys know I like to pick on our ER residents in our department. And this is multiple academic centers. And what they did was give everyone an implicit association test and measure their score, see exactly what their implicit biases were measured by the test. And then they gave them a clinical vignette, and they changed the race of the patient and offered a look to see if the gold standard of care was given for someone having a heart attack despite the changes in their race. And here's the data, right? And they separated the study into two halves: those who were aware of the study and those who were not aware. And we'll start with the unaware. That's the solid black line here, right? And the bottom of the graph is your degree of implicit association. So if you took the test and it showed you had a high degree of implicit association bias, and the left side is an odds ratio, right? The 1-to-1 odds ratio that you'll treat your white patients the same as your African-American patients. And the study's thrombolysis, because when the study was done, that was the gold standard of treatment for myocardial infarction. Now, obviously, it's a PCI, or percutaneous coronary intervention. And what they found is those who scored high on the implicit association test or showed a high degree of bias actually treated their patients worse or differently when you change your race, as opposed to those who had a low degree of implicit bias. And these are people who are unaware of the test. And it's only statistically relevant, right? And so it's important. But the better part of the study, I think, is what happens when you made the doctors aware of the study, right? Those who had a high degree of implicit bias, they just took that test and they walked into this exam. Look at them. They did a 1 out of 1. They almost performed flawlessly in this, right? And those who got a little confident and had a low degree of implicit bias on that test, they walked in and they did horrible in this metric, right? They did not treat their African-American and white patients with the gold standard of treatment. And that's fascinating. And what it really tells me is, one, in our emergency department, if we wanted to do a QI or a quality assessment, we should just put a sign outside of every door calling our doctors a racist, so they walk in the room on their best behavior, ready to engage. And I mean, I'm obviously kidding a little bit, but ultimately what it really shows us is that education and self-reflection can immediately reverse the differences in these disparities, right? The potential is so stark in this, right? And it's so exciting to see that if we just highlight the potential for biases, we engage, because the fundamental belief is that we are here to help people, and we engage in better care, in more equal care amongst our counterparts. And so, fascinating study. It's been replicated. This study, the idea that we're trying to associate or find clinical correlation with the implicit association test, has been replicated over several dozen times, over 40 studies. And the reality is, it's not a perfect test. And certainly, but it is a metric one can use to self-identify. And people can obviously get better at doing the test. I've done the test so many times, I can practically memorize the answers. But the big question here is, what can we do, right? And I'm sorry, I kind of cut some of these data points out of here, but standardizing practice and management. There's a number of studies that show, especially with chest pain evaluation, it's our more common one in the emergency department setting, in which we really highlighted how the outcomes, the disparity outcomes, right, the mortality rates of African Americans could be shown by these individual metrics, right? So triage scores, your likelihood of getting the correct test, the likelihood of missing the diagnosis. Those are relevant in terms of how they're being shown inside the overall outcome we care about, and that's mortality. So one thing you can do is standardize your practice and management, right? There's standardized triage scores. There's a number of studies out there that say standardizing triage scores can get rid of disparities, and not just racial disparities, right? These are just as relevant with gender disparities. And this is what I think is so important about this lecture, is that a lot of this data can be replicated inside Canada, even though you guys don't have the legacy of slavery, the social political system, the Black Lives Matter movement, but you guys are dealing with your own difficulties of having marginalized populations. And standardizing your practice, any attempt I have, I try and standardize my practice. And that's with triage scores, there are heart scores for risk stratification that allow you to take out any biases in your practice. With the pediatric head trauma, there's a PCARN study to help you assess for, and there's studies that show that any practice that applies these metrics or standardized metrics to their practice have ameliorated or mitigated these disparities. And so if you have a chance to apply a decision aid or a standardized metric within your department, I'd encourage you to do so. And I think this is important because at this point, I think we need to stop spending resources highlighting disparities and repeating studies, right? I think we don't have to repeat every study in the world to look at beta blockers, but we do end up having to repeat a ton of studies that identify that our own practice, my own individual practice, could have disparities in our pain management, right? And most of us would be aghast to identify this. And so I would just highlight any potential you have of eliminating bias, do it before it has to be highlighted for you, right? The next thing is education. And there's a number of studies that show that a longitudinal curriculum, exactly what we're doing here, but longitudinally integrated within the curriculum of medical students, has shown to help with these biases. And they did a similar clinical vignette test where they changed the race of the patient, and they looked at certain schools that perform well in terms of well-being, treating their white patients and their African-American patients equally. And they looked at what they had in their education curriculum, and every single one of them had a longitudinal engaged curriculum about racial disparities, health equity. And lastly, self-reflection. And this is what I hope everyone here from this lecture takes on, is that the idea that these biases are insidious. So you do not have to be a bad person. Racism, it doesn't make you a racist, but even if so, racism means we can't keep using this like a pejorative. We have to start identifying how each and every one of us individually we're adding to this problem that we're having, right? And if we're not self-reflecting, if we're constantly putting on to the structural components of racism, the people who are worse than us, like the Ku Klux Klan, we're never going to actually improve on our own metrics, because a lot of these metrics are being caused by those who have the best intentions.